Hello, everyone. Thank you for being part of this important discussion. I'm Nisha Morris, Senior Vice President at City of Hope, one of the largest and most advanced cancer research and treatment organizations in the nation. Before we turn to today's main topic, we want to acknowledge that cancer has been especially top of mind this week for another reason: former President Joe Biden's recent prostate cancer diagnosis. Our thoughts are with the Biden family as they face this challenge, joining millions around the world who are navigating the impact of this terrible disease. We've been following this news and have shared insights where we can be helpful. City of Hope is here as a resource, so feel free to reach out. Now, we're here to focus on a deeply concerning trend. Cancer rates are rising among younger women. Today, we will discuss what this data reveals, what we know, what remains uncertain, and how we can respond. We'll focus especially on expanding access to genetic testing and risk assessments, the vital role of supportive care, and the need to advance the research that leads to better treatment and prevention. We're joined today by distinguished cancer experts who are addressing this urgent issue. First, Dr. Hope Rugo, Director of City of Hope's Women's Cancer Program. Dr. Rugo is a renowned medical oncologist known for leading groundbreaking breast cancer clinical trials and helping to develop novel therapies. She has published extensively and is internationally recognized for her leadership in advancing women's health. Also joining us is Dr. Alpa Patel, Senior Vice President of Population Science at the American Cancer Society and a national leader in cancer prevention. Dr. Patel is a key partner with us in addressing this critical issue. We'll hear from Alyssa Cicada, a grateful patient of City of Hope and mother of two, who will share her cancer journey that began in her 30s, highlighting the challenges she faced in advocating for her health. Natalie Schneitman, Executive Director of City of Hope's Department of Supportive Care, will also be here and speak about the unique needs of women as they move beyond treatment and into survivorship, often for decades. And finally, Dr. Amanda Schwer, a radiation oncologist at City of Hope, who will speak to a unique phenomenon: younger doctors treating cancer patients in their own age group. I'll begin by inviting Dr. Rugo to start our discussion, after which my colleague Dan Loderman will facilitate the discussion. Thank you once again for joining us to address this critical issue. Dr. Rugo, please begin.
Thank you so much, Nisha and Dan and my colleagues. This is such an important area, and I'm thrilled to be here to talk to you about this, and also looking forward to our discussion. For more than 20 years, we've been seeing a concerning and steady trend, which is rising cancer rates among younger women under the age of 50, and in particular under the age of 40, which are now much higher than men of the same age, a reversal of prior trends. We're here this morning because City of Hope, together with our partner, the American Cancer Society, is calling for bold changes in how we treat, study, and talk about cancer among younger women. Many women are navigating a cancer landscape that to date has failed to address their unique needs, including the preservation of quality of life long after diagnosis. These are the patients that we treat that will be impacted by the side effects of treatment for many years. We need to recognize the opportunity to do more and rethink how we respond to this trend. We're particularly calling for change in 3 areas that I'll outline more below, with wider availability of risk assessments, a national standard for supportive care, and more research into what's causing this trend and how we can better respond to the unique biology of cancer in young women. So let's go into some detail about this. We've seen, based on the most recent data, that women under the age of 50 have cancer rates that are 82% higher than men at the same age. And young women, particularly those under the age of 40, have a higher risk of more aggressive, difficult to treat cancers. Now, it's important to keep in mind that cancer rates are still higher as women age and as men age. This is a trend among the group of patients who traditionally have had the lowest rates of breast cancer around the world. This hasn't been a sudden change, but a steady trend. And at the same time, encouragingly, mortality rates for many cancers, including breast cancer, has declined, which shows the impact of a greater understanding of tumor biology and targeted treatments. Unfortunately, this trend has not impacted women under the age of 40 to the same degree, highlighting the importance of understanding cancer in younger women. Why is change needed? We can treat many of these cancers, particularly at advanced treatment centers, comprehensive cancer centers like City of Hope. New therapies are allowing more people with cancer to live longer, even those who have incurable disease. And we are becoming progressively more successful each year, both with prolonging survival in patients with advanced disease and curing patients with early stage disease. But cancer research, treatment, and even our supportive care is still tailored primarily to older patients that historically, as I noted early, were most impacted by cancer. So given this disparities that we've been talking about in cancer rates, we need to rethink our approach in responding to cancers in our younger women patients and in women before they develop cancer. So we're calling for change in three key areas along with our colleagues, not just in the US, but around the world. For risk assessments, we're calling for wider availability of risk assessments that can help women understand their risk for early occurrence of cancer. And risk assessments include genetic testing when appropriate, understanding the impact of family history across different racial and ethnic groups, and lifestyle factors that impact the risk of breast cancer and other cancers, as well as the outcome of these cancers. This will allow women to know if they're at risk and may call for earlier or more frequent screening than current guidelines call for. It's important to keep in mind that risk assessments also include an overhaul of how we evaluate early cancers, because in young women, our traditional screening approaches, such as mammography, are not as helpful. Younger women have very dense breasts, for example, for breast cancer, and so we're really not picking up these cancers early. We find the cancers when women find a mass on exam, which is in general too late. And this is true for other cancers as well, when screening can be very complicated. Leading cancer centers like City of Hope are an important resource for genetic testing, but also for understanding an individual woman's risk for developing cancer. This can be based on many different factors, as I noted above, and extensive research is helping us to understand how we can better ascertain young women's risk of a variety of different common cancers. In terms of research, we also need an urgent change. We need to prioritize research for younger populations, particularly women. Although we are certainly contributing to science at City of Hope, women under 40 remain underrepresented in clinical trials, a gap that limits the development of age-specific treatments and personalized care strategies. Research can also help us understand what's behind this trend. And recent trials have helped us understand some quality of life impacts, like becoming pregnant after a diagnosis of breast cancer, for example. But we really need to improve the treatment options for these women and our supportive care, as we'll talk about more in this session. City of Hope is prioritizing research and clinical trials that meet the needs of this younger demographic. One example is the phase 2 multi-center adaptively randomized neoadjuvant phase 2 I-SPY 2 trial that's testing a number of different novel agents and novel agent combinations that are targeted to the specific biology of the breast cancer in the individual patient. This allows us to de-escalate treatment in patients whose cancers respond well, but escalate treatment in those who have more resistant cancers. This is a critical step towards improving treatment options. And then supportive care, as I've been mentioning. We believe in a national standard for healthcare providers and insurers to provide more supportive services for cancer patients. We all know that younger women have unique needs, and we have to address psychosocial support, fertility considerations, family life, workplace reemergence, and managing the long-term risk of recurrence and the anxiety about this risk. This should be a core part of cancer treatment, not something that's nice to have and not something that's dependent on a particular patient's ability to afford this that's not traditionally covered by our insurance. Even things as simple as hair loss with chemotherapy can have a major impact on patients, and saving eggs, for example, for future fertility needs is a critical area which we need to support. City of Hope is considered a national leader in supportive care. Later in this session, we'll hear from one of our supportive care leaders about why these approaches are so important for this patient population. I'll now turn the podium back to Dan to moderate our session.
Thanks a lot, Dr. Rigo, for those words and your very expert perspective. And thanks a lot to everyone who's joined today. Just a quick note, we do have the ability to take questions through the Q&A feature. We have some questions that have come in. If you have a question, please feel free to drop one in the Q&A, and a bit later in the discussion, we'll try to get to as many of those as we can. Dr. Rigo, I want to ask you a quick follow-up question. You've talked about key areas of change that are needed to better respond to cancer in younger women. Can you talk a little bit about what's unique about this patient population, such that the way that we're responding today may not be sufficient?
I think that there are several areas here. We have recommendations that are part of the U.S. Preventive Services Task Force. They recommend that mammography start at 40 instead of 50, but we saw from the data we have here and have discussed that many women under the age of 40 may be at risk. And we also understand that mammograms may not pick up cancers in young women, even those under the age of 50, but even in particular under the age of 40. We don't know what the best screening is, because if all women, for example, have MRIs, we're going to pick up a lot of abnormalities that are not cancer. This is a highly sensitive but not so specific approach. We're working on new testing modalities, but I think what we need to do is to understand risk for an individual patient. And there are a number of approaches that are helping women understand if they need to start screening at a younger age, because this can help women also understand the importance of self-screening with exams and going in for abnormalities that they find on exam or symptoms. We want to empower women to take charge of their cancer risk. So understanding risk is critical, and this is an important part of our call to action and new direction. So the simple tests for common risk factors, genetic mutations, these are easy to do now, are inexpensive, and are generally covered by insurance, family history and lifestyle. And I think what's important to keep in mind is that genetic risk may not be the most common and highest impact genetic mutations like BRCA1 and 2, but they can include less common, what we call moderate risk genetic mutations. These moderate risk mutations can impact the need for follow-up exams, self-exams, and specific screening. And so we need to be able to screen for these tests with genetic testing. So young women who are at higher risk can be monitored. They can take proactive steps to reduce risks by important counseling, and consider preventive medical options in consultation with educated and I think specific healthcare providers.
Thank you. I want to turn now to Dr. Patel. Thanks for being here, Dr. Patel. And the American Cancer Society, and you in particular, have been leaders in kind of tracking these trends and trying to understand what's happening. And but it's clear that there is some understanding of what's behind these trends and a lot that we don't know. Where are we in terms of understanding the science, and what is needed to help us better understand kind of what is behind some of what we're seeing in terms of rising cancer rates among younger women in particular?
So first, thank you so much for having me. And yes, we document these trends and produce the Cancer Facts and Figures document that shows what these trends look like over time. But then we need to be able to understand really what is driving these trends. And so if we look at something like lung cancer, we're seeing that there is an increase in lung cancers, particularly in younger women who have not had a long or extensive smoking history. So they're not eligible for lung cancer screening based on guidelines today. What is driving that is exactly what we need to be looking into. So we also are conducting really large population studies of individuals that start at age 25 or 30 and then follow these women over time to be able to understand what is driving these risks. Dr. Hugo touched on the fact that we don't understand enough about risk in younger women, and that is largely due to a lack of representation of younger women in these studies because cancer has historically been an issue of aging. There are environmental factors that we're examining. There are the combination of lesser genetic contributions, what we might call polygenic risk scores, and how that plays into it, because we see that many of these women don't have a prior family history. And we're also looking at different aspects of lifestyle. There's a lot that's changed in terms of the reproductive patterns of women. Women are having fewer children. They're having their first child perhaps at a later age. We're seeing, because of things like diet and possibly processed or ultra processed foods and growth patterns, that the age of menarche, or when your period starts as a woman, is actually getting slightly younger. So how are these factors playing into some cancers, for instance, like breast cancer, that are oftentimes hormonally driven? These are a lot of the different types of questions that we need to be able to look at the population level to be able to understand risk. A critical second component then is to understand, beyond the largely age-based guidelines that we have for most cancer screenings, how do we assess risk at different levels so that we can then think about how we might recommend screenings at younger ages for some women. Not all women need to, and we've heard from Dr. Rugo about some of the potential harms with screening someone who may have an abnormality that is not cancer. And so we don't want to overscreen, but we want to appropriately disseminate screening where there is benefit that outweighs potential harms. And that really comes with understanding risk assessment. And to that end, we have a really nice tool on cancer.org called Cancer 360 Risk Assessment that allows you to understand where and who may benefit from genetic testing, who may benefit from lifestyle modifications. There is a lot that we do know. We know that 40% of cancers are attributed to lifestyles such as avoiding tobacco smoke, being physically active, having a good diet, maintaining a healthy body weight, avoiding alcohol, and sun protection. But there's a lot that we have left to learn, and that's where research continues to be so critical.
Sounds like part of what you're saying is there's a lot we don't know, but that doesn't mean that there aren't steps that we can take and that younger women can take to manage their risk and respond to their risk. I think
without a doubt, there's a lot that we can do, and we know that. For instance, I do a lot of work on physical activity and cancer prevention, and we know that at virtually any age, there is a tremendous benefit for several types of cancer with following physical activity guidelines. So there are things that we know we can do, but there is a considerable amount left to learn.
I will say just one thing to add in your excellent comments is that, when a young woman gets breast cancer, it's really important, or any cancer, lung cancer, to understand that it's not their fault. And it's
Right.
They didn't exercise enough. In fact, the majority of women I see who are young are thin and exercise regularly in California. I don't know, it's different in different geographic areas, and we understand the risk. But it is an important area for all women to be able to impact their own health. So it's that very, very young cohort where those associations sometimes there's blame about what kind of food somebody ate, et cetera, and we really try and avoid that.
I think that's a really nice segue into hearing from Alyssa. And thanks for being here, Alyssa. Dr. Rugo and Dr. Patel have been talking about, the trends and the research, and you have been living this. And I think the comment that Dr. Rugo just made about trying to understand, why did this happen is something that you've been experiencing. Can you tell us a little bit about what it has been like for you to get a serious cancer diagnosis in your 30s, and how you have had to kind of fight for that diagnosis and for the care that you needed, and what it says about kind of this conversation that we're having?
Yes, definitely. Thank you guys for this opportunity. It's amazing to be on this panel with such strong, beautiful women. I appreciate that you guys are doing this. And an introduction, my name is Alyssa Cicada. And when I was just 35 years old, I was diagnosed with lung cancer. At that time in my life, I had been married for 11 years. My kids were just 5 and 7 years old. They were in kindergarten and second grade. And, I was just living what I thought to be a normal life. I was working full time. Everything was just beautifully chaotic, but I knew something was wrong in the background, because for about a year prior to my diagnosis, I had been dealing with a chronic cough and fatigue. And I brought those concerns not just to one, but 2 different primary care physicians in hopes that they would help me get to the bottom of what I was going through. And they ordered labs, which came back normal. And they really didn't think to order any additional imaging despite what I was telling them. And in the end, I had received diagnoses such as exercise-induced asthma, long COVID, just being a stressed out, overworked mother. And I was told that I just needed to take it easy. And I left. And as time wore on, my symptoms got progressively worse. And I got desperate. And I ended up having to go out of pocket and purchased my own CT scan, which actually found that I had a tumor in my upper left lung and some enlarged lymph nodes. And at that point, I took that information back to my physician in hopes that he would finally be just as concerned as I was, but he wasn't. He then tried to convince me that my symptoms and my mass that they found in my scan were likely just benign, that lung nodules, especially in young, healthy, active women like myself, are almost always benign. And I get it. I'm telling him that I'm sick, but what he sees is this. This is exactly how I looked at 35. I looked too healthy to be as sick as I told him that I was. So eventually I had to fight to get a referral to a pulmonologist. And over the course of about another month, I finally received additional testing that confirmed that I did in fact have lung cancer. And at that point, hearing the word cancer, your life just starts to fall apart. And I knew that I needed hope, and I knew I needed something better. And so I left my run-of-the-mill primary care physician in situation that I was in, and I went to City of Hope. And City of Hope then put me through additional screening and testing. And not only did they confirm that I had lung cancer, but I had stage 4 lung cancer that had metastasized to a lot of different lymph nodes across my chest region. I had cancer in my brain, and I had cancer in my spine. But the thing is, my story is not unique. I have met so many women who were in their 20s and their 30s who too came to their physicians telling them, hey, I have these symptoms, something is not right, but they were being dismissed. And what's worse is that they were too young to have any of the risk assessments done, like a mammogram or even a colonoscopy. And for myself, lung cancer, I never would have received any kind of risk screening because I'm not a former smoker and I was under the age of 50. So in the last 3.5 years, I have had to go through chemotherapy, immunotherapy, targeted therapy, surgery, and radiation. And it is not lost on me that had we caught my disease earlier, I might have been able to avoid a lot of these treatments. But fortunately, due to the fact that I've received these treatments, I've been able to live the last 3.5 years with what people have told me is an incurable disease. I get that I didn't fit the profile for what they would be looking for in a cancer patient. But I honestly believe that that's why so many women, especially young women, fall through the cracks. After I came to terms with my diagnosis and the fact that I was going to be on some kind of systemic treatment for the rest of my life, I knew I needed to get some kind of additional supportive care because, you have so many people telling you what you can and can't eat, what you can and can't do, and your head is just on a swivel. And so I sought out Dr. Lee, the integrative oncologist at City of Hope, as I call him, my naturopathic doctor. And I brought to him all the different things that I'd been told. And he and I came up with a game plan about things that I should be doing and that there were things that I should be avoiding. And that really helped at a time when I felt so lost and I had so much information to kind of climb through. He and I also discussed the importance of mental health therapy. I really wanted to pursue EMDR therapy, and at that time, City of Hope wasn't offering that, but he highly encouraged me to seek it outside of the hospital, and I did, and that was incredible for me because I needed that therapy, because oftentimes people think that cancer is just a physical battle, but when you're this young and you're juggling the struggles of motherhood and working, it's debilitating. The mental load is just excessive. And sometimes, at least for me, it has been worse than the physical. So getting that therapy and getting those tools early on really helped me, because I can't lie. After diagnosis, I was incredibly depressed. I didn't want to get out of bed. I just felt so broken. I felt like I'd been handed my death sentence. And how do I move forward with that kind of information? So getting that therapy truly helped put things into perspective, because I finally came to terms with the fact that, let's just say I get a few years. I'm wanting to make those years as great as possible for my kids, because they deserve that. They deserve a life and a memory of their mother where I wasn't broken. I'm sorry. I wasn't broken. I sought out the help and I showed them that I could do what I needed to do and give them the best memories that I could, even with the fact that I may only have a few short years left. And so that's just what I did. So moving forward, I wanted to close with the fact that I share my story because I know out there right now, there's somebody else going through this. There are many women going into their doctors and saying, hey, I have symptoms, but they're being dismissed. And they're not young, they're not old enough for these screening protocols. So I really do believe that risk assessment needs to change. I believe that physicians need to start listening to their patients and their symptoms and their stories, rather than just, checking boxes on a list. I believe that young women need to be offered mental health and integrative support early on and throughout this process. Because like you had mentioned before, losing your hair, losing your eyebrows, I was fortunate enough not to have lost that, but I know many women that have, and how your entire loss of identity is wrapped up in your appearance, right? And it's a lot. So I do hope moving forward that risk assessment changes, patients are taken seriously, patients begin to listen to themselves, and that we start to offer supportive care. And I guess I should mention now, my kids are 9 and 11 years old. I have a soon-to-be 4th grader, an almost middle schooler, and I didn't think I'd be here to see that. And I'm so grateful. And I look forward to the future and the treatments that are coming down the pipeline. And I hope that I can be one of those patients that says that I would be able to beat an incurable disease. And I hope moving forward, more patients aren't being diagnosed with stage 4 disease, especially when we can catch it at a time when it is treatable. Thank you.
Alyssa, I just want to say thank you so much for sharing your story. It's so powerful, and you're so brave. And, it's great to see you looking so well, and every year counts. It's remarkable. And I think your voice adds so much to empowering young women to really pursue and stand up for themselves, pursue evaluating their symptoms, as you did, and also pursue the best treatment path. And I think that's also really important, because once you were diagnosed, you really worked to pursue the best treatment path and the best supportive care, because it may not be the same cookbook approach for every young woman, and it certainly isn't for most. And that's a powerful message that you gave to us and to our greater community.
Thank you so much.
We echo that. Melissa, have gotten to know you and your story a little bit these last few weeks, and we're lucky to have you with us today, helping to share this message. And I think you are an example of what we are all trying to do in terms of drawing attention to this topic and talking about how we can do more. Melissa, there was a question that came in for you, and I just think while you're kind of sharing your story, it's a good moment for you to speak to it. You did a little bit, but the question was, what recommendations or advice do you have for other women who might not fit that profile and are worried that they may be falling through the cracks of the healthcare system?
You know, I've actually had this conversation with quite a few women, you know, younger and older alike. And the biggest piece of advice that I give them is that you don't have to have a PhD in yourself. You know yourself, you know your body. And as women and as mothers, we know when there's something off with our kids, right? And we will jump all over that to get to the bottom of it. And we are relentless when it comes to our children, but oftentimes we can be dismissive of our own symptoms. And that needs to change. You know, our families are only as strong as we are. We have to be there for them. And so that means listening to your symptoms, going to the doctors, and trying to get a diagnosis and treatment. And I get it. Sometimes it takes a while, but if you're not getting better and things are getting worse, you need to speak up. You need to let the doctors know, hey, things aren't improving. Something doesn't feel right. And if you feel like you're being dismissed, then go somewhere else. You have the right to go to another physician, and a good physician will encourage a second opinion. They will not be offended by it. You know, you don't need to worry about other people's egos when it's your life, right? You want to have good quality of life. So I guess that's my advice, is just listen to yourself. You are stronger than you think, and don't stop until you get to the bottom of it.
Thank you for that powerful message. I want to take a moment and kind of building on that powerful story that you shared, Alyssa, to invite Natalie Schneidman into the conversation. And Natalie is Executive Director of our Supportive Care Medicine program at City of Hope. And Natalie, I think City of Hope is often considered, you know, a national leader and standard setter in a lot of supportive care areas. And yet it's clear that there's so much more that needs to be done to meet the unique needs of this patient population. What is unique about this patient group, and what do we mean when we're talking about supportive care for this patient group? Alyssa touched on some of it. And what would it take to make that care more widely available for more people?
Yeah, thank you, Dan. And thank you so much for having me and for all our partners who've joined us today for this really important conversation. Let me start by defining a little bit. We're talking a lot about supportive care, which delights me. But what is it? Supportive care is the part of medical care that helps us treat a patient like a whole person, including the family and other caregivers, which, as Elisa pointed out very well, cancer is a family illness located in that patient. Supportive care focuses on physical symptom management, on practical support like finances, transportation to treatment, childcare, and more, and social, emotional, psychological, and spiritual concerns, some or all of which challenge every person with cancer and have significant impact on the ability to engage in treatment and the long-term quality of life. Supportive care, like cancer treatment, needs to be personalized to the individual, but we also know what certain groups are likely to experience. And so we can and should assess and intervene early. To today's topic, for young adults, cancer pushes this big pause button on life for long and very difficult treatment and brings one face to face with mortality. As Alyssa said, it blows up this beautifully chaotic life, and this is totally destabilizing during a life stage that's focused on building the future, a stage defined by growth, opportunity, and laying the foundation for the road ahead. Young women with cancer face particular challenges that can permeate every part of her current and future life. As examples, only a few, she may be in a young relationship or dating when body image and fertility concerns will be very powerful. She may be at an early stage in a career demanding time and commitment for success. She may be the mother of young children requiring tremendous energy and focus on caring for others who depend on her. She may be all of these combined and then some. And if she's in a committed relationship, that partner, who will likely have to be her caregiver, is also a young adult facing all the same life stage concerns. New therapies, as Dr. Rugo spoke about, are extending survivorship, and how we address these practical, economical, and psychosocial aspects of cancer and its treatment impacts medical outcomes and can influence the entire course of a person's life. So at City of Hope, as Dan said, we built a model supportive care department with an interdisciplinary team of experts to address those complex and interrelated supportive care needs. We have innovative programs such as Couples Coping Together Against Cancer that targets the significant strain on couples and families with strengths-based education and counseling. We have a lot more that we're very proud of, but even within our own hospital, we are unable to reach all the people who need us with what they need. And as you're hearing today, this has to change. So we are now focusing on more scalable, sustainable ways to reach more patients and families. And we've joined national experts as members of Together for Supportive Cancer Care, a coalition launched by the Biller Family Foundation with the mission that every patient and family with cancer will get the supportive care they need and deserve. We're working on replicable models of care, data that demonstrates outcomes of supportive care, and advocacy for changes in policy. And this is one place where we need help. We can join our voices, spread awareness, and call for action. As Alyssa said, sometimes the mental health and those other practical and social and family difficulties become even bigger than the physical ones. We need to help people get through this hard treatment and into a life that was worth fighting for, that hasn't fallen apart because we didn't address these supportive care needs. There's not a cancer patient that doesn't have some form of supportive care needs. So there should be no cancer care without supportive care. And this is the voice I think we need to raise. And thank you for joining us in this effort.
Thanks very much, Natalie, for that perspective. Just want to remind folks that you can submit questions using the Q&A. We've had a few questions come in, and we've hit some of them, and we'll turn to some of those in just a moment. Dr. Schwer, I just want to give you a moment to weigh in on the conversation. You are also, I think, seeing firsthand a lot of what has been discussed today. And I just wonder sort of what it has been like from your perspective to see more younger patients, younger women patients, and what that has kind of revealed about the particular challenges of getting a cancer diagnosis, in your 20s, 30s, or 40s.
Yeah. I'm just so honored to be a part of this group. Alyssa, that was incredible. Thank you so much for spending time and letting us hear your story. And my peers, thank you for your perspectives. I hesitate to even for a second make this about the provider, so I'm not going to do that. But I will say this is getting hard. We're seeing this every day. And, in medical school, we're really trained to think of cancer as a disease that develops later in life. I mean, you just don't even think about it. But in my clinic, every single day, so many of the women I see are in their 20s, 30s, 40s. There's been several times where all I have to do is look at my schedule for the day, and a majority of my breast cancer patients are younger. Not even just that there's some of them, it's that the actual majority is younger. That this morning, just for some anecdotes, this morning, two of the patients I'm treating, one's 41, one is 39. They both have stage 4 breast cancer that has spread to their brain. Both with young children. And it really, again, I don't like to make it about me. I'm so lucky. I am in my 40s. I have young children and I'm healthy, but honestly, there have been several times, and I've done this for years. And there have been several times in my clinic where I've had to take a break to kind of compose myself because of these stories that we're seeing and the complexity, the emotional complexity, the physical complexity of everything these patients are dealing with is just a lot different when you're younger. And as a younger woman myself with children, I just empathize so much. And again, it's really just starting to affect us. And it's happening in my personal life. It's happening in my professional life that we're just seeing these stories over and over. I mean, it used to be, I'm in my mid-40s now. It used to be, once every 6 months, I'd get a call from a family member or a friend. It's now honestly weekly that one of my friends gets breast cancer, and I call City of Hope and I have to call in a favor to try to get them seen quickly. And it's really, really an issue, which is why I'm so glad we're doing this today and getting this word out, because we really do have to empower women to be heard. We need to educate physicians to listen we hear stories like Alyssa's all the time. I felt something in my breast, but I was 26 and I was told I was too young. It must be a cyst. You know your own bodies, be your own advocate. And for doctors out there, we need to listen. So those are the main takeaways, is that this is real and it's really, really palpable in our clinics these days.
It's very powerful. Thank you for sharing that perspective, Dr. Schwer. I know there's a lot of clinicians at City of Hope and other organizations that are feeling that same way. Maybe we can open up the discussion a little bit, and also looking at some of the questions that have come in. And a number of questions have touched on risk assessments, and this is something that several of y'all have talked about. And I think for Dr. Patel, Dr. Rugo in particular, can you talk a little bit more about what we can do to better understand risk? Are we talking about the need to evaluate screening guidelines? Are we talking about insurance coverage for risk assessments? Are we talking about a certain standard or age by which those assessments should take place? What specifically would need to change to understand risk in the way that you all have talked about is needed to kind of meet this rising cancer rates among younger women?
So I can share that, current guidelines are generally looking at a certain threshold of absolute risk of developing a particular type of cancer, and that is who is then recommended for screening. Again, weighing the risks and the benefits of having the screening, how many screenings have to take place for one cancer to be found, and understanding holistically what that care path looks like. And so I think the first very critical need is for us to understand, given these alarming trends that we're seeing, is what is driving risk in some women at younger ages? What is contributing to that? How does lifestyle, environment, genetics, all of these different factors, we know that it's not just one thing. How are they contributing to the overall likelihood of developing a particular type of cancer? And then that evidence will inform how guidelines should change. As guidelines change, insurance coverage typically follows. So, several years ago, we saw that as we were documenting these trends in earlier onset of colorectal cancer, we first documented these trends with the work that we do here at the American Cancer Society, and that led to recognizing the need to lower the age of screening for colorectal cancer from 50 to age 45 of someone that we would say is of average risk. I think the big challenge right now is helping to disentangle what is considered higher than average risk, what is considered average risk, and what level of risk is tolerable to subject or not subject someone to a screening test. We don't want to, and we don't have the capacity to test every single woman from age 18 to older, but how do we actually appropriately disseminate that kind of screening? And the one other thing I will say is that Dr. Rugo touched on this earlier, is that some of our current screening modalities, like mammography, may not work as well for younger women. So we also need to continue to do research to develop additional effective ways of identifying cancer in these younger populations as this disease burden is shifting.
Thank you for that. Dr. Rugo, we also have a couple questions that have come in related to research, and I want to try to combine them here. You talked about some of the areas of focus for research in your opening remarks. You have talked about the importance of new and different treatments, less toxic treatments for this patient population. Can you share a little more about sort of what the next frontier looks like in terms of research into new treatments that would be a better fit and could potentially help younger women with a cancer diagnosis survive longer and have a higher quality of life?
That's a big question. It's lots of different components, but I think that, what we understand now, and it's interesting because over the course of my career, this understanding has really changed dramatically. What we understand now is that we have sort of drilled down a little bit on the subtypes. The most common form of breast cancer is hormone receptor positive. What we understand is that type for type, young women, particularly those under the age of 40, have a worse outcome with the same treatments compared to older women. And that's fascinating because we don't understand it. We thought we'd already drilled down to the right biology. So now there's a lot of work going on trying to further understand and pick apart the differences in younger women. Is it that cancer grows in an estrogen-rich environment and those cancers have overall a different biology in response to therapy? Is it the type of therapy? It doesn't appear to be the type of therapy because studies that have looked at premenopausal women have seen for the same type of cancer a worse outcome in very young women. And so that understanding of being able to look further into what's driving the biology of these cancers is critical. We also know that in young women, we see an overrepresentation of the most aggressive forms of breast cancer, those that lack estrogen receptors or are positive for HER2 gene amplification. And we're trying to tailor the treatments for these women where we could understand if you got the same aggressive treatment, some women's cancers will respond beautifully and others women's will not. Do we need to give the same treatment to every woman? We don't. What we want to do is understand the biology and then individualize the treatment to the patient's age and their cancer biology. And we can do that by treating patients up front before surgery who have early stage breast cancer and observing the response so that we can give less therapy for the fast responding cancers. But also we need to urgently do work to understand which of these cancers is not responding to treatment and how we can better employ new treatments to improve outcome. And we're doing that in the neoadjuvant I-SPY 2 trial in patients who need chemotherapy for their cancers, but we're also trying to improve the hormone treatment options for women as well. But closely attached to this, which you mentioned, is that the treatments are tough. We're impacting fertility, which is a critical issue, and we don't want to close the door for women if we can avoid it. And so it is never too much time to take 2.5 weeks to harvest eggs before you start treatment. And that's a critical area. People are saying you have to start treatment tomorrow. This is not the case for almost all solid tumors. We need to be sure that we have paved the road for a future that's rich with possibilities and not close that door. And then during the treatment, we need to recognize the issues that face young women. Suppressing estrogen production from the ovaries for a woman who's 32 is really tough compared to a woman who's 48. It's not the same because a woman who's 48 is producing less estrogen. The impact for women and our ability to work around the treatment options and sequence them and manage the side effects proactively is critical. That's why we need to have a really comprehensive team, care providing team. You may see your physician or your advanced practice provider every 6 months, but you need to have access to the team and be able to manage symptoms on a regular basis because your symptoms aren't going to wait 6 months if you're miserable. So we really, I think, at a comprehensive cancer center in a comprehensive clinic situation, we want to provide that level of supportive care as well as the understanding of treatment options for each individual patient, focusing on both their individual needs and their individual cancer.
I want to ask, and we've just got a couple more minutes. I want to ask a follow-up to you, Alyssa. Hearing this discussion from Dr. Rugo and Dr. Patel and the other members of our panel, you've talked a little bit in your story about feeling frustrated to not understand, what may have been behind your diagnosis, and finding out sort of later in the process that there was a genetic driver and wondering kind of what impact that might have had. And I wonder from your perspective, how important it could have been and would be for other women to be able to better understand your specific risk and feel like you could act on that versus some of the kind of powerlessness that you have described that has made your experience particularly challenging.
So my situation is unique because I didn't have a genetic driver like a BRCA gene that could have been detected before my cancer. I mean, even when I was diagnosed and City of Hope ran a genetic profile on me, it didn't detect any genetic drivers that were driving my cancer. And so I went into treatment, and it wasn't until going through a remission and having a reoccurrence that we finally found out that I had a genetic driver called ALK positive that was driving my lung cancer. But it wasn't something that was genetically passed down to me. It was just something that happened and had kind of laid dormant throughout my diagnosis. But fortunately, in detecting that particular genetic marker, it opened up. It was at a time when my treatment possibilities were closing, and it opened up a lot of different treatment possibilities that were a lot less, had a lot less side effects than normal chemotherapy. For example, now I'm taking chemotherapy in pill form, which I'd prefer to do than being in a chair every 3 weeks with a needle in my arm. I don't know if I'm completely answering your question, so please correct me or guide me if I'm not, but I do know other patients and friends who have ovarian cancer or breast cancer, and they have said, gosh, I wish that I could have gotten a genetic test done with my annual well women exam, and maybe it could have detected my genetic BRCA marker or whatever it is that they had that was driving their cancer, and then maybe they could have caught it before it developed. And you hear about that, right? What was one of the recent celebrities, a few celebrities have been able to get that as part of their genetic workups are being done in their checkups, and they're catching these things before it becomes cancer, and they're staying ahead of it. But the rest of us, the rest of the population, we don't have the same access to that. And so, yeah, I wish they would have been able to detect something prior to my cancer, but that just wasn't the case. But I'm still grateful that they finally did find my driver, because that has really helped in my treatment journey.
We've just got a minute or two left before we have to wrap up. We've had a lot of the questions that have come in. Just want to kind of open it up and invite Dr. Rugo, Dr. Patel, Alyssa, Natalie, or Dr. Schwer. Any kind of last comments, in particular with an eye toward sort of where do we go from here, and what message do we have for younger women out there and others in the healthcare system and in our society that can help us better respond to these trends? Any closing thoughts?
I'll just say briefly that, I think that we've taken an important step in continuing to document these trends, and there is an immense amount of research from prevention through treatment and supportive care to understand why these trends are happening and how we can change them. But I would say that I think overwhelmingly what I've taken away from this conversation is that don't discount the most important piece of that, which is to be your own biggest advocate. The research, the tools, the treatment, the strategies will be there because of exceptional places like City of Hope, where treatment can be delivered, but you get there through being your own biggest advocate. And I think that to me is really the message that I hope women take away from hearing this.
Yeah, I would agree. I mean, I think that, of course, and I think that the take-home message is that this is a critical area for us to focus on as a community, as certainly in the academic research setting, but as a community at large. We want to empower young women to pursue evaluating symptoms or findings on exam and trust themselves. But we also want to empower young women to seek the best care possible and to seek opinions, even if not encouraged to do so within their provider network. If they question something, it's important. And then we also want to empower providers and our population at large to focus on this as a critical research issue, to understand better the biology behind cancer in young women, to offer young women the best possible treatment options that aren't a cookbook design, and to offer young women the best supportive care. And this is really critical because there's so much fear associated with a diagnosis of cancer that sometimes those critical supportive care areas can be overlooked. We need to encourage our young women who are at risk or who develop cancer to really stand up for themselves and do the best that they can. And increasing awareness for those of you who are participating in this webinar is a big step forward in making these goals a reality.
Yeah, thank you for that, Dr. Rugo. We're just about on our time. I want to really thank each of you for being here, lending your expert perspective, your personal stories, and helping us shine a light on this topic, both in terms of what we're seeing and what can be done moving forward. And on behalf of City of Hope, I want to really thank Dr. Patel, you and the American Cancer Society for being terrific partners, and Alyssa for being here and sharing your very powerful story that I think is going to resonate with a lot of people. This is a topic that we will be continuing to talk about. City of Hope is committed to progress in this space and elevating the stories of women, both patients and clinicians who are experiencing these challenges while we continue to advocate for change. So thank you very much for everyone who attended and participated today. Thank you again to our panelists, and we look forward to continuing this discussion moving forward.
Thanks, Dan. Thanks, Alyssa, Nisha,
Thank you.
colleagues on the line.
Thank you. Take care, everyone.